Good morning, everyone. And we start this topic, what the role of EOS in esophageal cancer with these subheadings. The overview is, it is the most common cancer, and squamous cell carcinoma is definitely more common than adenocarcinoma. And early esophageal cancers indicate T1 tumor. The applied anatomy is important because we have to know what is the cervical esophagus, what is the upper esophagus, what is the middle, and what is the lower part of esophagus, and what is the abdominal part of esophagus. So the cervical esophagus goes from 15 centimeter to around 20 centimeter, upper from 20 to 25, middle from 20 to 30, lower from 30 to 40. We see this is how the cervical, middle, lower esophagus. This is important, and we need to know because the epicenter of a tumor is the most important thing. If epicenter is less than 2 centimeter in stomach, this is called cervical esophagus. If epicenter is more than 2 centimeter in stomach, this is included in C of stomach. In this case, for example, the epicenter of the tumor is in the stomach. The CA esophagus can be localized, stage 1 to 3, or it can be advanced. Local can be only local or regional. So what we call as loco-regional is when the tumor is local, T1 to T3, and regional with N1 to N3 nodes. So preoperative TNM staging is mandatory in surgical candidates because accurate staging can change the expected plan of management. So the role of EOS in esophageal cancer may be debatable as most of the patients undergo chemoradiation regardless of the stage. So the esophagus travels through 3 compartments: neck, chest, and abdomen. The chest has a peripheral compartment and a central compartment. Ideally, the spread of the problem should remain within one compartment, whether it is central compartment or whether it is peripheral compartment. Because the spread to another compartment means more extensive disease. This is the classification. When we see the classification of lymph nodes, American So the classification of lymphatic drainage of a stomach is important because how do you do the lymphatic drainage of a stomach? How do you do lymphatic drainage of esophagus?
Stay muted. Stay muted. Click on the slide.
So the lymphatic drainage of esophagus is important. So the lymphatic channels are single cell thick as lymphatic capillaries. These are the lymphatic capillaries lie near the mucosa. So these are the lymphatic capillaries and they lie in each layer. They lie in lamina propria, submucosa. This is the lymphatic plexus, intermuscular lymphatic plexus, and adventitia. So these are the lymphatic plexus which lie in each layer of the esophagus. And ultimately, the aim of these lymphatic capillaries is to drain via the thoracic duct in a cranial direction. The lymphatic plexus are present in all layers of esophagus, but they are most abundant in mucosa adjacent to lamina propria and in submucosa adjacent to muscularis propria. So this is important factor because this determines as to what will be the mucosal dissection or removal of tumor in early esophageal cancer. You can see this is the lymphatic in lamina propria and submucosa as the most extensive one. The only thing is in submucosa, the spread is both in a cranial as well as a caudal direction. The lymphatics go from lamina propria to submucosa, but from submucosa they can go in a cranial or caudal direction. And the spread of metastasis to node is longitudinal in upwards and downward direction, because this is the tumor spreading into the submucosa. But then it goes up as well as down in the submucosa. From epithelium, the mucosa, it goes into submucosa, but at submucosa, it becomes a bidirectional spread. And from this bidirectional spread, it can spread outside into the periesophageal and paraesophageal node. So this CT scan shows tumor of esophagus at 35 centimeter distance. No nodes were seen. PET CT showed no activity outside esophageal wall. And this type of skip metastasis are common in esophageal carcinoma. This is the paraesophageal lymph node near the aorta due to skip metastasis. So submucosa can drain, but at some places it has to eventually go into periesophageal nodes and then into thoracic duct. So from submucosa, lymphatic drainage can go into periesophageal node and into thoracic duct both. From submucosa, it can go also into adventitial plexus, which lies outside the muscularis propria. Less often, the muscular drainage, the lymphatic drainage goes into intermuscular lymphatic plexus. But the main flow, whatever happens, is outward towards the thoracic duct or into paraesophageal nodes, from which it can join the bronchomediastinal trunks or the thoracic trunk. So there is a new term, bronchomediastinal trunks, the thoracic duct or the bronchomediastinal trunks. They ultimately drain into the junction of jugular vein and subclavian vein. The flow from the nodes, subcarinal nodes, are the central station, and they are frequently have a size of 1 to 1.5 centimeter. And this is the point of drainage into jugular veins, where ultimately the lymphatic drain will happen. Right flow is more than the left. The flow on the right side of trachea is more often than the left. Upflow is more common than down. So right flow is more than left, upflow is more than down, but still the flow occurs in both directions. So up and right more than down or left. So then the bronchomediastinal trunks are larger lymphatic vessels which drain the right and left paratracheal nodes. They go into the right and left paratracheal nodes, go into the bronchomediastinal trunks, which are shown as yellow color trunks on either side of the trachea. Their bronchomediastinal trunks are separate from the thoracic duct. Or they represent the thoracic duct. This is the drainage of thoracic duct. The bronchomediastinal trunks are additional lymphatic channels which drain the paratracheal nodes at the junction of jugular vein, internal jugular vein with the subclavian vein. So the bronchomediastinal trunk open independently into the junction of internal jugular and subclavian veins of the same side. Sometimes the bronchomediastinal trunk may open into the thoracic duct. This is a case which shows the joining of azygos vein into the superior vena cava, and this particular lymph node is above the lower border of azygos vein and seen on right side and is labeled as 4R. So this is the general pattern of lymphatic drainage that we have explained, that you have bronchomediastinal trunk apart from the thoracic duct going in a cranial direction and ultimately joining. So the TNM staging of esophageal cancer. This is the TNM staging, the Tx to T4b, and then regional nodes to N3 nodes, and then the distant metastasis. But we must learn that these are the muscular layer, and as we can see, this is the layer 2, 3, and 4. So this layer 2 is the submucosa, layer 3 is the muscularis propria, and layer 4. In these cases of esophagus, the fifth layer is actually a layer which is interface of the outer esophagus and the adventitia, and not actually the serosa. So the tumor that is T1, T2, T3, T4, they are shown in this figure, and N1, N2, and N3, these are the. What generally T4 indicates is mediastinal invasion. T4A is considered potentially resectable tumor, and T4B is unresectable tumor. So mediastinal invasion is a variation between T4A and T4B. The surgeons want to resect tumor, whether it goes into pleura, pericardium, azygos, vein, diaphragm, or even sometimes peritoneum. The word potentially resectable means that you downstage and then remove it. So a little bit of anatomy is important because below the manubrium sterni lies the inferior mediastinum divided into posterior, middle, and anterior. The pericardium and the heart defines the middle mediastinum. The posterior mediastinum lies centrally within the chest, and centrally within it lies the esophagus. So mediastinal invasion can occur anteriorly, posteriorly, or laterally. Generally, when people think of mediastinal invasion, they are only thinking of aorta. But mediastinal invasion is when the esophageal tumor has spreaded anteriorly or posteriorly or laterally into one of the following structures. So when we see T1 tumor, it is only available for modalities endoscopic ultrasound, and high frequency probes are more accurate, considered more accurate. But today with the 13 megahertz probes available in US and tissue harmonic imaging availability, even the probes are pretty good. The only thing is we need a thinner probe to lie in the middle of esophagus and provide enough focal distance to provide good resolution of the esophageal wall. This is a CT scan would be useless in this case of early esophageal cancer. And this is again an early esophageal cancer where an endoscopic ultrasound was able to show the presence of tumor. When the tumor is T2, the sensitivity is very high, but overstaging can occur because of peritumoral inflammation. For example, this is a T2 tumor involving 30% of circumference of esophagus, and there is no node, but this patient was referred for surgery. Till the tumor is T1, it can be operated. But the moment it becomes T2, the tumor cannot be operated, cannot be endoscopically subdissected. Till it is T1 tumor, it can be removed by EST or EMR. So this is an esophageal lesion, which is about 1.2 centimeter diameter. So in this case, upper GI endoscopy biopsy twice was negative. And this is a 1 centimeter tumor involving FNAC showed of the wall showed adenocarcinoma. So sometimes you have to do FNAC of the esophageal wall, and this patient was then referred for surgery. So the wall FNAC is an important thing, except sometimes you may fail to find a tumor in the esophageal lumen. So this is a esophageal lumen tumor. The T3, the sensitivity becomes even higher, and US sensitivity is relatively high for T3, and specificity is high in other T stages. So understaging occurs in 3 to 15% of cases. This is a T3 tumor. The movement of pleura is seen. The vertebra is not involved. And T4 tumor are usually non-traversable tumor. And when it comes to EUS, the sensitivity and specificity is high. And for mediastinal invasion, esophageal tumors are the most important tumor. But in this case, the aorta as well as the common carotid artery is involved. In this case, the tumor is going into the left atrium, inferior vena cava, right atrium and inferior vena cava. In this case, the mediastinal invasion is happening into the bronchus. The N staging, as we said, is N1 is 1 to 2 regional lymph node, N2 is 3 to 6, N3 is more than 7 nodes. So this is the basics flowchart that when we look for T and M staging, the tumor can be local, advanced, regional, N1, N2, N3. Non-regional, it can spread to neck, mediastinal abdomen, or metastasis. So we have to identify the classification, the IESLC classification. I will not go into great details, just show that this any staging of advanced esophageal cancer can be from cervical, celiac. And prognosis of celiac lymph node is poor. Once upon a time when there were celiac nodes, it was considered that in an esophageal cancer you cannot operate. Then the field operation came. Field is where regionally cervical lymph node, 2 field is cervical mediastinal lymph node, or 3 field cervical field is mediastinal field, abdominal field, 3 field concept is there. But as I said, the field concept is not important, but nevertheless it is important to know this lymph node is above the arch of aorta, belongs to station 2, and this lymph node T3N1 tumor, paraesophageal lymph node, 4R station. These are again T4 tumor with pleural invasion as well as presence of node cluster, 3 nodes lying in different clusters. And this lymph node is above the arch of aorta on left side, is belonging to station 10. Then we have M staging in advanced cancer. So whenever you do esophageal cancer staging, do T staging, do N staging, do M staging, and then you do the complete staging. And in this case, we can do SOL or left atrial staging. Endoscopic ultrasound is also used in restaging of cancer, relapse of esophageal cancer, whether it is recurrent carcinoma or not. If it is recurrent carcinoma, EUS can be used. And in this case, there was a recurrent carcinoma of the wall of the esophagus, and the FNAC was done again from the wall, the FNAC of the wall concept. So how do we do? What are the steps? And these are last couple of slides because my time is up. We are running 10 minutes late. So we will review the endoscopic findings always before US. What is the length? What is the circumference? What is the lumen diameter? Always endoscopy, because endoscopic ultrasound, we must be able to see the tumor. And then we see the locoregional tumor, advanced tumor, map the T stage, N stage, and M stage, do the lymph node classification, complete all CT imagings before US, and consider to add cervical region, chest CT, pelvic region, abdominal CT. The question is, should US be performed before or after CT? And should we integrate PET CT into US or not? So what does EUS say? What does PET say? And do they say the same thing? And ultimately, this is a multimodality imaging. To identify the purpose of EUS, you are doing it for diagnosis, you're doing it for staging, or you are doing it for pathology. This is the purpose. So this is the basic purpose. The review endoscopic finding, review CT, identify locoregional, advanced staging, identify lymph node, complete other staging before EUS, and then this is the purpose of EUS You may select mini probe, select radial probe. You can select a smaller scope, bronchoscope, EBUS scope, whatever scope you want to try. And this, then you do iodine mapping, endoscopy, identify the tumor, and then you follow up all these cases. So the US need is always different. In this case, just last slide showing the agarigous vein, the tumor, but the agarigous vein is not involved. Mediastinal invasion is not there. In this case, there is a lymph node, and these are the various cases of lymph node. So I will take my leave and I will give the platform to the next speaker,